Welcome everybody to the 24th virtual shadowing program. Today we are going to be talking about pediatric endocrinology with Dr. Carlos Leyva. For the month of November and into December, we are having a specialty spotlight for clinical pediatrics next week. The week after, we're going to be going over emergency medicine. The week after that, gastroenterology, and then after that, the path to becoming a nurse. And so be on Zoom or YouTube Live at 7 p.m. Central Standard Time. Okay, and so this is our working group. And so we have Reagan, Mishayan, Taylor, Anna, Rachel, Anirudh, Mayam, Rohit, and we have Dr. Fowler, Dr. E, and Dr. Salazar as part of our team as well. And all right, and I'll leave this for Dr. Salazar.
Well, good evening, everybody. You've all been so patient and so grateful, and I've been putting a lot of updates on my Instagram account. And so finally the night is here where I can bring you some really big news. So the big news is we now have a learning management system. We wanted a system that allows us a live webinar style that allows plenty of interaction with you guys, allows certificate generation. We can record these, they can be posted, you can watch them all with a single login. And the most important thing for us, we wanted to keep it affordable, under $30 for the entire length of the course. So we're really, really excited to do that. We attended a final meeting today with those fine folks. I'll reveal their name in the next couple of days as we sign that contract. But it's very nice to know we now have a platform that we can be really proud of. So we're done recording the very first episode already, and we'll be looking to get that out to you here in the next couple of weeks. I'm gonna finish up a couple of items. I'm gonna put my Instagram information here in the chat. Make sure you follow me. I put very good content every day, give you updates and lots of cool pics. And so that's the really big news. I'll be putting that on my IG here shortly. Indulge me in one more thing. If you thought that taking tests was going to be done after you graduated medical school and residency, you are very, very wrong. Absolutely. Okay. Please join me in wishing Dr. Fowler good luck in his final recertification exam tomorrow. This is his final one. He's recerted many, many times. I never want to do that many like Dr. Fowler, so wish him good luck. You got this. We'll be praying for you and we love you. So lots of great news tonight, guys. Really excited to get that program started.
All these good luck charms flowing into chat, Gil. Thank you so much.
You're welcome. Perfect. All right. And so throughout the presentation, we're going to have 2 question and answer sessions. Maybe one in the middle and then one at the end. So throughout the session, just feel free to enter your questions into the Zoom chat or the YouTube live chat, and we will get to them as much as we can. Okay, and then here is a little Dr. Leyva. Fowler will take it away.
All right, so welcome everybody. It's so good to have you here. We have almost 1,000 people online with us here, plus whatever's on YouTube Live. It's so good to have you back for our 24th session. Virtual shadowing has been an astonishing success. We would never have predicted. We had almost 31,000 people who come to the website and logged in to want to participate. So it's been a tremendous thing. And as we've said all along, we're going to be here as long as you keep coming back. So anyway, welcome. Good to have you. Thanks for coming. Tonight, we have a wonderful guest to join us tonight, and you're just going to thoroughly enjoy this session. Dr. Carlos Leyva is a pediatric endocrinologist in Puerto Rico, and he is a very, very special individual. He is the director of a clinic that he has established, which you will talk about, getting into such issues as pediatric weight management and bariatric surgery. He was the founder and pediatric endocrinologist of his clinic there in Puerto Rico that he'll tell you about. He is a board member, physician advisor, pediatric endocrinologist appointed by the governor of Puerto Rico. This is a story of a fellow that just is such an amazing person. Born in Arlington, Texas, good old Texas. He was a Dallas Cowboys fan since birth, but not lately. But he grew up and was raised in Puerto Rico. And at the age of 12, he was diagnosed with type 1 diabetes. And he's going to talk to us about his perspective as an endocrinologist about the management of diabetes, especially in the setting of absolute insulin lack. And he will talk to us about that. So we are, and the list goes on. Carlos, we are so very, very delighted to have you join us this evening. And so without further ado, I will stop taking your time, and everybody put in chat, welcome Dr. Leyva, and take it away, Carlos.
Well, thank you, Dr. Fowler. Good luck tomorrow. It's very, I have to say, just the night before, taking an exam and being here, and it tells a lot about yourself and the dedication to this program. Thank you for having me, and thank you for the group for helping out with the preparation here of the presentation. So like Dr. Fowler said, I'm a pediatric endocrinologist here in Puerto Rico. He went over a little bit of the background. So I founded this, my main clinic is a center. We have also in the process. We're supposed to open this summer the pediatric weight management clinic with the bariatric surgeons, but due to the pandemic, we had to delay the opening. So hopefully in January, we're starting that program, which is the first one in Puerto Rico and the whole Caribbean. We're having multiple specialists there. It includes nutritionists, exercise physiologists, psychologists, a pediatric GI physician, pediatric cardiology physician, the bariatric surgeons, and myself as the director. So I'm very excited about that new project that we're starting. And so I'm faculty member of two big hospitals here in Puerto Rico, and also a board member of the main academic diabetes center in Puerto Rico, which is the one that is appointed by the governor. So a little bit of my background. We can go to the next slide, please. So a little overview of the presentation today. Let's go back to the overview slide. I'm sorry, I don't have the control. Let's go back, overview. There you go. So the first part of the presentation, I'm gonna talk about a little bit about my life experiences, and how each part of those life experiences impacted my future professional career in pediatric endocrinology. I will give some tips and that I learned through all those experiences, and how that has helped me in my future professional career as well. Hopefully it can help you guys. I understand there's some high school students, undergrad students, so hopefully when we talk about those specific time periods of my life, it could hopefully help you guys with that, regardless if you end up doing pediatric endocrinology or not, or doing medicine or not. After that, we're gonna have like they mentioned, a question and answer session in the middle of the presentation. And the second part is going to be mainly about my specialty and my subspecialty in pediatric endocrinology, and what I've learned of being a pediatric endocrinologist here in Puerto Rico. And then there's going to be another Q&A session at the end. I understand there's going to be, you can write in questions, and then the folks in the group are going to help out to kind of pick the questions and answer them. So let's go to the other slide. All right, so like Dr. Fowler said, I was born in Arlington, Texas. I was born there in Arlington. So my father is Cuban, my mother is Puerto Rican. My father kind of, after he moved from Cuba to Puerto Rico, met my mother, got married, and they decided to do their master's degree back in Texas. So they went to do their master's at, back then it was called North Texas State University. Now it's University of North Texas. So they did their master's degree there, and they stayed there. They worked in Texas, and I was born there. So after, I think when I was 3 to 4 years old, they decided that they wanted to move back to Puerto Rico so I can grow up with my family. All my family was back in Puerto Rico. My grandparents, my uncle, my aunt. So we moved to Puerto Rico. Okay, so that's how I became, Dallas Cowboy fan. I was born, my first, little baby suit was a cowboy jersey. So I've been a fan since I was born of the Dallas Cowboy, but I put here not lately because this year has been the most disappointed year, at least for myself. Even when we were 1-16 back in '89, this has been I don't know, it hasn't been a fun year this year. So that's why I put, but not lately. I'll be a Dallas Cowboy fan. So I grew up in Puerto Rico. I was raised here in Puerto Rico. Then when I was 12 years old, I was diagnosed with type 1 diabetes. I'm going to get into that later on in terms of my diagnosis and of course, my impact on my professional career. After that, we moved when I was in 10th grade. My father got transferred from work to Florida. So I finished high school in Boca Raton, Florida, my last couple of years, so junior and senior year in high school. Then I went to college at the University of Miami, Hurricanes. Then I went back to Puerto Rico to do my medical degree in Ponce School of Medicine. Stayed in Puerto Rico for my pediatric residency in San Juan, and then went back again to Miami to do my fellowship program in pediatric endocrinology at Jackson Memorial Hospital. So I've been kind of back and forth between Puerto Rico, Florida, born in Texas. So I've been back and forth, and you'll see that when we go through all my lifespan and how it impacted my professional career. Let's go to the next slide, please. So I'm going to start with my childhood years and how that impacted my professional career. So I know there was someone I forgot the name. I'm sorry, I'm really bad with names, but someone was a soccer player around here in college. So I used to play soccer since I was, 5 years old. In Puerto Rico, soccer is not, well, now it is, but back then it wasn't common sport. Here is baseball and basketball. So I started playing soccer. And really that experience of playing soccer and the sports, it really helped me a lot in terms of leadership role. On a few occasions, I was captain of my soccer team. And really that helped me a lot in terms of not only later in college and later in medical school, also now when you're working in terms of how to deal with a group of people. So those of you guys who are high school students and doing sports, doesn't matter, it could be soccer, basketball, that experience of leadership or working in a group is going to help you a lot in the future. So I know soccer impacted my life, and I played soccer till last year. I was in the senior league and I was getting injured. I was more injured than actually playing. So I kind of retired from soccer last year. So I just run now and do exercise on my own. No more soccer for me. But I play soccer up to, also in college, I played for this university. I played during medical school 1 year. I don't know how I did that, but I was able to play one semester for a semi-pro team here in Puerto Rico. So soccer is it's something that later on my kids also ended up playing soccer as well. So my type 1 diabetes diagnosis. So that really, in your lifetime, there's some events in your life that really impact from that point forward your life. And of course, that diagnosis for me, it did. You can see the picture of myself there. It says World Diabetes Day, November 14th. So this, I think Saturday is for the 14th. It's the World Diabetes Day, and this month is the month of awareness of diabetes. And that blue circle is the symbol for diabetes. So this is I kind of this, when they told me about this date, I was like, oh, this is awesome, because this is the week that we're really involved in educating people about diabetes. So this is a great opportunity for me to later on, we're going to talk about type 1 diabetes as well. So
Carlos, this is Fowler. How did your diabetes show up? Did you become acutely ill when you were 12 or 13-year-old?
So it's really the classic story that most of my patients, when they're diagnosed, it shows up. So like I said, I used to play soccer, and it was during the summer. And I remembered that, I'm not that tall. I'm short. I was really short back then, and it's very skinny. And I was always running around throughout the field playing soccer, this and that. But I was starting getting tired. And then in the middle of the game, I had to go and to the bathroom to pee. And then when we're in a long trip, we had to stop a lot of time for me to go to the restroom. And then I was constantly thirsty all the time. And it started losing a little bit of weight. So my parents took me to my pediatrician, and they told them about my symptoms, and he requested some labs. And I remember I still that number, my first blood sugar, when they told me it was 697. That number is still 30 years later. I don't forget that number. The reason I don't forget is because when we went to pick up the results from the lab, the lady in the lab told my mother, "Hey, I didn't know the kid was diabetic." And my mom is like, "No, he isn't." And she kind of realized the mistake she made. And she's like, "Oh, no, you need to go to your pediatrician." So of course they took me quickly to my pediatrician, saw the labs, and then they sent me to the hospital where there was a pediatric endocrinologist. And you'll see there's certain people in your lifetime that really impact you in different ways. And you'll see throughout my presentation that there's 3 or 4 of them that my professional career was kind of pushed because of them. And one of those people was my pediatric endocrinologist that, pretty much taught my mother and with the diabetes educator and everybody about my condition. So you'll see that I always talk about condition. I don't talk about my disease or illness, because if we take care of ourselves, people with diabetes, and I'm talking mainly type 1 diabetes in my case, really those complications really are avoidable. So it becomes a disease when you really do not take care of yourself. So that's one thing I always tell my patients. It's like, when I talk to the first time to their parents, I do not talk about complications. I don't even mention it, because really, if they take care of themselves, those complications they're not going to get there. The only time I start talking about complications is when I see that the patient is kind of not doing the things that we're recommending, not taking care of themselves. That's when I go, hey, this could happen if you can continue doing this. So this diagnosis, so that story about, peeing all the time, constant thirst, those are the symptoms of high blood sugar. And we're going to talk about that also more in details in terms of lab work and this and that. But so that's the classic pretty much story with patient. And if my parents didn't know a lot about symptoms of diabetes, so they thought it was summer. Here in Puerto Rico in the summer is very hot. I know in Texas it is, and I don't know, there's people around the world here watching this, but here in Puerto Rico, summer is hot. So they thought, okay, it's very hot. He gets thirsty. He needs to drink a lot of fluids. He's drinking so much fluid, he has to get rid of those fluids. So that's the way that most people who do not know about the condition will think that it's happening to their kids. So my story is the classic story with all the kids that are diagnosed with type 1 diabetes. So as you can see, sure.
Carlos, do you think that yours was an acute immune thing due to Coxsackie virus, or was it congenital, or what do you think?
So we know that type 1 diabetes is an autoimmune condition. For those of you guys who do not know what autoimmune means, we have an immune system that defends us from viruses, bacteria, this and that, right? And in autoimmune conditions, it means that your own body makes antibodies that attack your own cells. So in type 1 diabetes, we know there's a certain antibodies that attack the cells that produce insulin, the beta cells. And that happens for a long time. It happens years, takes years for that to start destroying those cells. So I do some research here in Puerto Rico. I'm part of a network called the TrialNet Consortium, where we look at family members of patients with type 1 diabetes, and we can determine if they're high, middle, moderate risk, or low risk of having type 1 diabetes. And through that study, we've known that there's a lot of them that have antibodies for years, and then they develop the condition later on. So it's a slowly progressive condition, but there's also needs to be a trigger. So the viruses, there's some viruses that are considered triggers to that. And actually, I'm going to talk also about the Coxsackie virus in one of the areas we're going to talk. So Coxsackie virus and other types of viruses are triggers, but it's not the cause of it. It just kind of pushes that final immune response to finally kind of destroy those cells. So it's an autoimmune condition that is different than in type 2 diabetes. Type 2 diabetes is not autoimmune. It's usually when we see it in adolescent patients, it's due to obesity because they're resistant to insulin. But we'll talk also about insulin and that in the clinic in the second part of the presentation. So you can see that type 1 diabetes has been has impacted my future from now on and from that point on in terms of how my life was going to change. Pretty much changed my whole life. I remember back then that I wanted to be an archaeologist. That was what I wanted to do when I would get older, and then when I got diagnosed with type 1 diabetes, that idea kind of changed and decided, ended up studying medicine. So in my childhood years, you can see that playing soccer, doing sports impacted my future, and of course that event of having type 1 diabetes being diagnosed also did. If you can change to the next slide. So high school year. So this is Dr. Fowler. I put here article about type 1 diabetes. So it's interesting because when I was in high school, I read this article. It wasn't in a medical journal. I was in ninth grade, and I think it was a Time magazine. I read an article, and they were talking about the Coxsackie V virus as a positive, maybe a cause of type 1 diabetes. In immunology back then, it was kind of a new science, kind of, there's a lot of immunology, so you've been learning a lot. So I read that article and I was kind of interested in on it. I say, hey, I have this condition. I want to learn more about it. So I decided.
It went from the stage of thinking that maybe type 1 diabetes was congenital, that it was inherited, to that it actually was an acute illness caused by a virus.
So in terms of congenital, so we knew, okay, so when we look, for example, I have type 1 diabetes. My kids have, if I'm a male patient with type 1 diabetes, my kids have 5% chance of developing type 1 diabetes. Okay, so there's a genetic predisposition, but it's not that high. 5% is not really that high. So it's not, we know that there's some genes that make you resistant to developing type 1 diabetes, and some genes that make you susceptible to developing type 1 diabetes. You can have the susceptibility genes, but if there's not a trigger, like for an example, the virus, then you don't develop type 1 diabetes. So in terms of congenital, in terms of you're born with it, you have that gene that makes you susceptible, but not necessarily you're gonna develop the condition. So in terms of an acute illness, usually when patients are diagnosed, there's at some point there could have been a trigger, a virus that ended up causing it. So in my case, when I look back at my history, I remember a year before I was diagnosed with type 1 diabetes, I got chickenpox. There was no vaccine for chickenpox then. And I remember prior to that, I had, my regular routine annual labs. My sugars were fine. And a couple a month later, I think I had some labs done. They were fine. And then a year, pretty much almost to the point, a year later, I was diagnosed with type 1 diabetes. So I believe there's no way so I can that I can verify that, but I believe maybe chickenpox was my trigger for me to develop type 1 diabetes. And in my family, there's no one else with type 1 diabetes. So there's no, most patients with type 1 diabetes, there's no family history of type 1 diabetes. Although there are some cases that we have twins or fathers with type 1 diabetes or mothers with type 1 diabetes that their children do get them. So there's a genetic predisposition, but it's not as high as in type 2 diabetes, which is pretty close to 50% higher risk of the patient having type 2 diabetes if they're obese, if there's a family history. I don't know if you kind of clarified that, Dr. Fowler.
But that's type 2, though, correct?
That's type 2. That's type 2. There's something called neonatal diabetes. Neonatal diabetes, they're diagnosed in the first 6 months of life. All right. So half of them, they require insulin for a lifetime, but the other half, they don't need insulin. They use sulfonylureas as treatment. So that's when I have residents rotating in my clinic, I always tell, the medical history is so important. Taking a good history is so important because there's a lot of people out there that could have that they're diagnosed with type 1 diabetes and they could have neonatal diabetes. Instead of insulin, they might just need a pill and their blood sugars are even better than with insulin. Of course, there's not a lot of them out there, but the way to know it, if you were diagnosed before the 6 months of age, then you need to consider having neonatal diabetes. There's some genetic tests that need to be done in order to determine that.
But I thought type 1 was an absolute lack of insulin. Can it be a relative lack? Is that what you're saying? Because if a sulfonylurea works, that increases insulin secretion from the pancreas. Isn't that right? I think that's what it does.
That's correct, but that's for neonatal diabetes, which is different than type 1 diabetes. Type 1 diabetes, pretty much, we know there's different degrees of severity of type 1 diabetes, but most of them, we don't produce insulin. It's pretty much negligent. There's not enough. And the reason, I'll go to the basics of the science for the benefit of the people who are watching. So the function of insulin is go from the pancreas to the blood and get the glucose that is in the blood, right? So we eat, the energy gets converted to glucose, insulin comes in, picks up that glucose, and takes that glucose inside the cells. That's where the glucose should be, right? So in type 1 diabetes, type 2 diabetes, they do produce insulin, right? But for example, they might be obese, so that the fat tissue doesn't allow that insulin to kind of get that glucose. That's called insulin resistance. So they do produce insulin, but it's not working well. So they use there's multiple oral hypoglycemic medications used that helps that insulin work better. Some of them, when they're being chronically with the condition, eventually the production can diminish and then they require insulin as well. In type 1 diabetes, we do not produce enough insulin, no insulin. Therefore, the treatment is insulin, and insulin is only given either by subcutaneous insulin pumps. There's an inhaled insulin, but that's used only for type 2, not type 1. So we have deficiency of insulin, and that's the main difference between type 1 and type 2. And of course, also the cause, which one is autoimmune, the other one it's either nutritional, weight, and we know there's multiple other types of diabetes as well, but I'm not gonna get into those details. So I don't know if I went over all those questions, Dr. Fowler.
No, just keep telling us your story about how you migrated from Texas to Puerto Rico, then medical school, and then I guess part of your interest in endocrinology was your own personal interest as far as dealing with diabetes yourself. Is that true?
That's correct. Yeah, that's the main interest. And so during those years in high school, I put here about science fair projects. I put that because after reading that article, I decided, okay, I want to learn more about my condition. You know, I know the basics, and I was taking care of myself, and my parents were helping me out as well. So I started doing all my science fair projects about diabetes. So I did the effect of exercise on my diabetes. I did different projects of that. And the purpose, I learned a lot, but at the same time, I educated my friends, my peers, my teachers, and when I'm talking with my patients, some patients, they really do not like to say they have diabetes, but they shouldn't be, they shouldn't feel, ashamed, because it's a condition that they're not, it's not their fault. So during high school, those of you guys who are high school students, and if you're interested in a certain topic, use those projects, trying to read and not only educate yourself, maybe you can educate other people as well. And what we're doing right now is educating you guys in terms right today about pediatric endocrinology. And so in my high school years, that part of the science fair projects helped me a lot in terms of my future professional career. If you can change the next slide, please. So I went to college. I told you guys I went to University of Miami. And then in college there, I knew there was this center called the Diabetes Research Institute. So my first semester at college, I worked in the library through the Federal Work Study Program. They'll pay me just, kind of minimum for, part-time. I really hated that job. And I wanted to go to the center and kind of see what they were doing at this research institute. So I went there, kind of started knocking doors, until I met this doctor who was another person who really impacted me and kind of also pushed me towards my professional career. Her name is Dr. Norma Canyon. She's right now one of the top researchers in type 1 diabetes. And I met her. She has a daughter with type 1 diabetes. So I talked to her. I said, I'm interested in just observing and doing the research that you do. She did preclinical research. This is bench research, and she was working with eyelid transplants in monkeys with type 1 diabetes. So eyelids, for those of you guys who do not know, is the area in the pancreas. So there's different cells, alpha and beta cells, and the beta cells are the ones that produce insulin. So they would transplant those eyelids into this monkey with type 1 diabetes, and temporarily they would cure diabetes in these monkeys. The only problem is that they required, the immunosuppressive medication and drugs, and eventually, there's the side effects of those. So I started working there, and eventually I was able to get paid while I was doing that initial volunteer kind of observership. So that was awesome. That was a really good experience. So for those you guys in college right now, also move around, just look. If you're interested in something, knock at doors. Some might be closed, some others will open up, and you'll see later on that experience of mine at the DRI really helped me actually getting accepted in the pediatric endocrinology program. Also during those years, I was transitioning from being taken care of a pediatric endocrinologist to an adult endocrinologist. And those of you guys who have chronic conditions since childhood, that transition can be very difficult, because you kind of get accustomed to this doctor, and also you have to change. You're on your own. You have more responsibilities. So I remember I went through like 3 different adult endocrinologists. Sometimes I felt like I knew a little bit more than they did about my condition, until I finally met this endocrinologist, who, by the way, I don't know, Dr. Fowler, he's in the same hospital that you are. He's in UT Southwestern, Dr. Luigi Meneghini. So he's an adult endocrinologist, and he was that third person that really moved me towards my professional career. He knew a lot about technology and diabetes, and put me on my insulin pump for the first time when there was not a lot of people on insulin pump. And so that's another experience there in my lifetime that helped me move in my career. And next slide, please. So medical school. So I applied to medical school. I went back to Puerto Rico for medical school, and that first year, remember I talked about leadership and how soccer helped me that, trying to work and be a leader. So that helped me a lot in medical school. I became vice president of my class. And then with a friend of mine, we were doing some community work on our own in the town where the medical campus was. And we started writing a proposal for a grant for something that we wanted to do, a community-based learning program. Then we found out that there was 2 physicians and the professors in the medical school. They were also writing a proposal. So we kind of combined the proposals, and the medical school got a really big grant, and they were able to establish the community-based learning program. And then, without knowing this, my future wife was one of the persons who was hired to work on that program. So I met my wife in medical school. We got married while I was in medical school. She already had a kid. He was 2 years old back then. And then after that, we had a kid. So during medical school, I was being a father. Was married. My wife was working. She was also doing her master's degree. So it was tough, and I don't know, eventually some of you guys who are in medical school or eventually get medical, be married with kids. So you have to balance all that work, and it was tough, but it really, another experience that helped me in the future to deal with other stuff that it really is minute compared to that. Financially, medical school, I had to, this school I went to it was a private school, very expensive. So I needed to get loans, and between that, raising kids, so financially was tough. So I was getting a lot of loans, still hopefully finishing up paying those loans soon. And then during those years, I was debating. I knew I wanted to do endocrinology. So I had type 1 diabetes. I knew I wanted to go to medical school. I wanted to do endocrinology. I was, most of you guys, when you go to medical school, might not know what you're going to go into. You want to do medicine, but really do not know. So I was kind of maybe the last common in terms of that I knew what I wanted to do. I just wasn't clear if I wanted to do it through pediatrics or through internal medicine. So I did my rotation in pediatrics, and did my rotation in internal medicine, like pediatrics more. And then I was able to do a couple of rotations in the States. I did 1 month at Boston Children's, and then another month at Miami Children's. And I did both of them, pediatric endocrinology. Love pediatric endocrinology, not only about the diabetes parts, everything else. So I knew I wanted to go through and ended up doing pediatric endocrinology. So that was in medical school. That's, my 3rd year of medical school. That's when I kind of decided that I wanted to go into pediatric endocrinology. Next slide. So did my pediatric residency in San Juan, Puerto Rico. The pediatric residency at 3 years. Really, when I did my residency, there were still not those, nowadays there's that time constraint that you do 24 hours plus then 8 hours without contact. Back then when I did it, there was still the old way. You work 30 something hours, no sleep. I think towards the end, I think in my 3rd year, that's the process when they start making the change of having restricted hours. So no sleep, but it's an extremely important learning experience. I mean, that residency is so important. You learn so much. Here in Puerto Rico, the facilities, the hospital facilities, they're not as great as the ones in the States. But we still, I forgot to mention, the medical school and all the programs are the same as in the States. They're accredited the same way. We take the same exams, USMLE, step 1, step 2, and all those. So it's the same curriculum, same books. It's in English, although there's a little bit of Spanglish there. So, to talk in Spanish, but you take exams in English, and it's kind of different here in Puerto Rico in that sense. So extremely important learning experience those years. During those years, in my program, we needed to do a research. It's just basic research. It's for you to kind of go over IRB. IRB is Institutional Review Board, and how to submit a work through IRB. So it's kind of learning experience. And for that research, I wrote a small book, a diabetes guide, in Spanish, because there was a lot of information that was given to the new onset diabetics, but it was mainly or either in English or not. If it was in Spanish, like not enough. So I wrote this book, and which to this day is the one that I use for my new onset patients. That's the first introduction about their medical condition. And so I did a little bit of research if that helped their knowledge. And I didn't reach my end in terms of number of patients. I think I needed like 75 and got up to 60. Not a lot of time to do all that work during residency, but it still helped me nowadays, that what I did in residency. And also there's the financial aspect. As a resident here in Puerto Rico, you get paid not a lot. So there's that financial part of the pediatric residency program. Next slide, please. So pediatric endocrinology, as I mentioned, went back to Miami. Pediatric endocrinology fellowship is 3 years. Okay. There's some in pediatrics. I think also specialties or fellowships are 3 years. 2 years mainly of clinic. The 3rd year is kind of research with clinic. One recommendation, which at least worked for me, keep notes of everything, or just somehow digitalize it. Back then I was just writing notes, and nowadays I have all that in my iPhone. But I have all those notes from what my attending was talking about with this extreme rare case, which I thought I was never going to see, but I did see them later on as an attending. So keep notes of everything, keep it in a file. I call it my second brain, because sometimes I go back to those notes to kind of look for different things. And then I did research. As I said, I went back to University of Miami. I did research in the same place where I did the research when I was in college. And I know when you're applying to this programs, fellowship programs, there are not a lot of positions. And at least in pediatrics, there's, the usual programs are 1 or 2 per year. Larger programs could be 5 or 6, but you're competing with a lot of people. So I know that experience that I had during my college years gave me a better chance to getting into this fellowship programs. So something that happened before helped me also in the future. So finish my fellowship. That's when all the job offers come in. And you see all these opportunities, especially financially. I've been mentioning all the financial constraints that I went through. All of a sudden you see this amount of money and you're like, wow. But I knew I wanted to go back. I wanted to go back to Puerto Rico. And so I was still looking at those offers. I stayed 1 year just doing general pediatrics while I was still debating if I was going to stay in the States or go back to Puerto Rico. Next slide, please. Next slide. There you go. So I went back to Puerto Rico. Actually, I needed to get a loan to start up my practice. So you can see here that I needed a loan to start up as business proposal. So this is the business aspect of medicine that really is not taught enough in medical school and residency and in fellowship. It's something that you learn, on your own pretty much. So I had to write a business proposal in order to get to apply for loans for banks. Commercial banks wouldn't give me loans because I had a lot of student debt. So I eventually got a loan through the SBA, Small Business Administration, and I was able to go back to Puerto Rico and open up my practice. So that's one of the reasons, like I wrote here, a lot of us from Puerto Rico, they moved to the States to get their specialties, and most of them stay in the States. You get all of a sudden this job offers, and then when you have to go, if you want to go back to Puerto Rico, it's tough to get him back, especially the financial part. And then you need to learn how to negotiate with the health insurances in terms of payment, how much you're going to get paid for seeing patients. So that's the business aspect. My wife helped me a lot in that because she did she actually worked for one of the insurance companies while I was in residency. So she knew, what are the things to do in terms of negotiating with health insurances. So
Carlos,
went back to Puerto Rico.
how did that make you feel, borrowing all that money to get started? I did the same thing back in 1982 here in my hometown in west of Atlanta, Georgia, where I built an urgent care center. So how did you feel going into all that debt?
I was scared. I remember already I had 3 kids. So my third kid, it was born during my fellowship. So raising kids with that, and then you want to start up in the beginning when you start getting the patients, it's tough, it's scary, but I was it's all getting organized. My wife helped me a lot in that. I'm telling you, my wife pretty much carried me throughout my education years. She was the one working, especially in residency, pretty much raising the kids because I was sleeping in the hospital most of the time. And nowadays she's actually the administrator of the center. So she's the boss still, and she's the one who knows everything in the business aspect. I learned a lot from her. So I have that advantage, really, I had that help from her, but it's still a difficult process. It's not impossible. So I don't want to, say people say, oh my, I don't want to study medicine. This is tough. It is tough, but if you really, this is what you want, hey, it's gonna work. It's gonna work. If I was able to do it, I know everybody else could do it. That business part is not the fun part. And, writing a business proposal, I have no idea how to do that. So, started asking and writing it, going to the bank and presenting this. But actually, now that business proposal, I remember I mentioned at the beginning that we're opening up a pediatric weight management clinic. So one of the things I wrote in that business proposal was that idea. And when I presented to the actual hospital I work for now, I went back, let me look at that business proposal, let me change. And I can, of course, update it, a lot of more extra information. And when I presented to the hospital, this is the project I want to do. I used that business proposal that I used 10 years before when I opened my practice. So it's scary, but it's doable. And there's a lot of tools. There's a lot of tools out there that actually, the business proposal, I remember going to the American Medical Association. I have to tell you the truth, I wasn't a member of it. And I became a member because I needed to get that book that is showing me how to write a business proposal for a medical practice. So I got that book and helped me with the business proposal. Of course, there's in the website and the internet, there's a lot of information for that.
Carlos, I remember I was in my late 20s. I'm now 60, be 68 Friday. And so over 40 years ago, I was borrowing all this money to build an urgent care center. And I think of all the mistakes that I made in business, just foolish decisions here and there. And so I think it's very important that for those that are listening tonight to be sure that you get good, sound financial advice from folks who can help you structure your loans, your business plan, and so forth. Because if you don't do that, you will very likely make some mistakes that perhaps could be avoided. I didn't mean to interrupt, but I just wanted to chime that in.
No, and that's true in terms of in that part of negotiating health insurance. Usually when, at least in Puerto Rico is that way, you go and they tell you this is the fee we pay for your specialty. And when you're starting up and you're really your need of having that income coming in, you kind of pretty much accept that initial offer. So that's what nowadays you can try to get it might cost some money, but it's some investment that you'll get a return pretty quick, and investing on someone who can guide you to let you get sign contracts adequately, make sure that contract you're signing for that job it doesn't affect you in the future. Sometimes you'll see when you get out of your fellowship, they tell you if you leave before this time, there's a range of miles. And sometimes the amount of miles is like you cannot work in the state next to the state you're applying. So those little things that they don't teach you, that if you get someone who can teach you and help you with that, it's a really important investment.
Yeah, so Carlos, how did you learn about negotiations with health insurances? Was there a book that you read somewhere? Did you take a course? How did you learn about it?
Right. So this was my wife, really. My wife was the one. She was the other side back then. When I was in residency, she was she worked for Humana here in Puerto Rico in the provider department. So she was in the other side. So she knew what insurance do when they're trying to sign a provider so we knew from the beginning we're not going to accept what they were offering from the beginning. I did my research in terms of what a pediatric endocrinologist should get paid. I called other pediatric endocrinologists in Puerto Rico. Yeah, a couple of them were professors of mine when I was a resident, and so learn how much they got paid. The amount in terms of fees in Puerto Rico is less than in the States. So you kind of find out how much they get paid in general. For example, you can go to Endocrine Society, American Academy of Clinical Endocrinologists. You'll find what is the income for pediatric endocrinologists, and you have an idea. So then when you go to the insurance, you say, okay, this is the amount that I should be getting paid in the ballpark. So a lot of mistakes, especially here in Puerto Rico, is for as soon as they graduate from their residency or fellowship and they go to insurance, they sign quickly. And after you sign that contract with that insurance company, in order to be able to raise that fee, it's hard. It's very hard. It's a little bit different in Puerto Rico than in the States, but in the States, there's some similarities as well. But answering your questions, mainly my wife pretty much knew a lot about that stuff, and looking at other resources also as well helped me. So next slide.
All right. Well, thank you so much for sharing your journey with us, Dr. Leyva. We all enjoyed hearing about your upbringing. And so this is going to be our first question and answer session. And so I will go ahead and read off some of the many questions that our students are wondering. Okay, so the first question that I think that I saw a lot of people were wondering, that you mentioned that during medical school you continued to play soccer. Is this a matter of time management, or is the exception that medical students will hardly have free time?
Well, I did it for, it was in my second year, first semester. It was time management, really, because the curriculum is the same as in the States. So maybe they say, oh, there was that school he went to was really easy. It was time management. I lasted only one semester doing that. At least I did it. I know I couldn't do it in a full year. I just needed to do some exercise and kind of release some tension. And the team I used to play for, I knew I couldn't go to all the practices. They didn't care. I guess they wanted me to play. So I went to a few practices and then I went to the games. But it was more really time management. But it lasted just a little bit less than a semester.
Well, that's great that you were able to fit that in. And so I guess another one of the questions that the students are asking, is type 2 diabetes considered to be an autoimmune disease or a metabolic disorder?
Type 2 is more considered as a metabolic disorder. Type 1 is autoimmune. Maybe I got them confused there. Type 1, autoimmune condition. They're mainly type 1 are mainly diagnosed in the pediatric age. We can get them as young adults as well. There's other subtypes of diabetes, the LADAs, the MODIs. There's of course those are more into details that I'm not going to get into. But type 1 autoimmune, usually diagnosed pediatric age. For some reason, we're getting them diagnosed earlier nowadays. In Puerto Rico, we have the highest incidence of type 1 diabetes in the Western Hemisphere in terms of incidence. So we have a lot of patients. Right now, I have 2 new onsets in the hospital right now, and we're an island of 3.25 million people, and we have a really, really, really high incidence of type 1 diabetes. We actually do have a high incidence of all autoimmune conditions. So for some reason, of course, type 1 is one of them.
So Carlos, what's that about? I mean, if it's an autoimmune condition, is it viral? Is it contagious? Is it an epidemic? What is it?
So we know autoimmunity. It's multifactorial because let's say, for example, type 1, in terms of, going back to type 1 diabetes, when we compare Puerto Rico to, for example, Cuba, Venezuela, which are, countries that are close to us, and genetically we're kind of similar, Cuba, Venezuela, have low incidence of type 1 diabetes compared to us. So genetic wise, you say, it's not genes, then it's what is environment. But when you look at environment, then you compare, Venezuela now is different, but back then, the diet intake was similar to Puerto Rico, and we still had higher incidence of type 1 diabetes. So this is multifactorial. This is genetic, it's environmental. There's something called epigenetics that we're studying how environment changes your genes. So autoimmunity, it's multifactorial. It's not one specific thing.
The comment about epigenetics is very interesting because the more that we study the human genome, the more it's apparent that there's so much that we simply don't know. And how, the old Lamarckian theory that the giraffe stretched his neck so high, and so the next generation of giraffes had longer necks. We no longer believe that, but we also know that there seem to be things that occur in the human genome that, based upon some sort of environmental or circumstantial thing, ends up becoming inherited. Very, very interesting.
It is.
I didn't mean to interrupt. And I know that Cheyenne's got a bunch of more questions for you. Cheyenne, please.
Sure. So another question a lot of students are wondering, how difficult was it, or is it in general, to start your own business as a physician?
So I'm going to talk more in details about that in the second part of the presentation. But it's when you have everything set up, it's easier, right? So sometimes when I got those job offers, I was gonna just get in there and start seeing patients, right? So there's some pros and cons that I'm gonna talk about. The difference in terms of practice, having your own private practice, academic setting, and maybe a mix of both. But it is difficult. But then it depends also in your own personal view. For example, I was more the type of person I like to do things my way, this way. Didn't like a lot. Okay, this is the standard. This is the way it's done. You keep doing it this way. I'm more okay. I want to do it this way and be my own boss. And so if you have that type of mentality, maybe private practice and start your own, your own business or your own practice, it's the way to go. So it was more a combination of my way of seeing things and that I wanted to go back to Puerto Rico, and that's how I ended up doing establishing a private practice initially.
This is a tremendous discussion so far. It's been so revealing about your own experience with a significant medical issue and how you dealt with that, going through medical school and then having a family, and then starting a business, and then borrowing money. And at the age of 43, you're still standing after all these years. So this is terrific. So we're at 1 hour and 5 minutes. You want to go ahead and go with your next part of your session, Carlos?
Sure, it's up to you guys. If there's more questions they want to ask, we can do that. The second part, I think, is going to be a little bit shorter than the first part, but it's up to you guys. If there's more questions, we can answer those questions now if you want.
Well, we're collecting the questions on the back end, and so we'll have another session in about 20 or 30 minutes, okay?
Perfect. So let's go to the next slide. All right, so my pediatric endocrinology. So my day-to-day, this is my day-to-day, could vary depending on what you're setting. So mainly, my 80% of my patients I see my day is in outpatient clinic. 15% or so it's in the hospital setting, just doing consults. And then I do some, I kind of mentioned a little bit of clinical research, clinical trial. I have one clinical trial, a couple of other 3 studies going on right now. So 5% of my time is on that. I really like research a lot, and it's not for everybody. I think that experience at the DRI kind of really, I enjoyed it a lot, and I always wanted to have to do something research-wise, although it's clinical research, not bench research, but I still do some of that. So the difference, this is kind of answering that other question about private practice, group practice, academic setting. So benefit of private practice. So the benefit is you're on your own boss. You do your things your way. The vacations, you decide when you want to take vacations. So so in that sense, it's a good part. Not the more difficult part is that you have to the business part. You have to do a lot of the business aspect of the running a clinic. You probably have an administrator, but you're still involved with making those decisions and personal decisions. So those are the pros and cons of private practice. Group practice, you have kind of cover yourself. So from private practice, I don't have when I'm on vacation, I don't have someone to cover me. So what happens? Those patients are if they ended up in a hospital, they get transferred to another hospital where there's another endocrinologist. We still communicate with between each others. We're a total of right now practicing eight or nine pediatric endocrinologists in the island. It seems a lot, but we're not enough. we're not enough. We my next initial appointment if someone's gonna get an appointment with me, it's probably here from 4 or 5 months to get a new appointment or so. We're not enough. Group practice, the benefit is you use there's already things are set up. If you go into already established group practice, if you're opening a practice with a partner, then in terms of coverage, in terms of the financial aspect of investment, you divide that. The cons is that there might be difference in opinion on how to do things, and especially if you're starting up, then it could be some issue there. And then, of course, the academic setting. If you like teaching, so academic setting is the way to go. I have the benefit that where in the hospital I am, there's a pediatric residency program, so I still do teaching, which I like as well. And so I have a little bit of that aspect of academic setting where I practice right now. In terms of pediatric endocrinology, in terms of economic and financially. So in general, pediatrics, when you compare to internal medicine, in internal medicine, some specialties tend to get paid more than in pediatrics. And that's in Oregon, and in the States, it's similar as well. Pediatric endocrinology, and we don't do procedures. In my clinic, we do stem tests, but it's really, it's not really a procedure. So when I put that dollar sign next to procedures, everything that is interventional, surgeries, colonoscopy, endoscopy, those things tend to bring more money. So since we do not do a lot of procedures, so economic wise, we don't get paid as much as other subspecialists. Okay. Pediatric endocrinology, I put it, it's kind of the old-fashioned medicine. You need to sit down, do a complete medical history, complete physical exam, especially consider that we follow purity, growth. So we need to do a complete physical exam in the kids. We request a lot of labs, all those hormones that we need to request to determine, different conditions and diagnoses. And then we need to interpret all those labs. So it's kind of, I put it, it's a term I use, old-fashioned medicine. It's a history, physical exam, look at labs and interpret those labs. That's pretty much pediatric endocrinology. But there's a huge need of pediatric endocrinologists. Like I mentioned here in Puerto Rico, but in the States, it's the same thing. There's a high incidence of all of those conditions, not only type 1 diabetes, obesity is a major condition that we see, thyroid disease, pubertal disorders, growth, adrenal issues, pituitary issues. So there's a lot of medical conditions and a lot of need for pediatric endocrinologists. So in terms of job opportunities, there's going to be a lot of them, because there's a big need. So that's, so you're pretty much have a job to secure and options to pick as well if you do pediatric endocrinology. Next slide. So in the day-to-day, so most of our patients, I would say the main conditions that we see is type 1 diabetes, obesity, purity, growth, and thyroid. Type 1 diabetes patients, the technology is moving so fast that there's a lot of work that you need to do to download the data from insulin pumps, what we call continuous glucose monitors, CGMs, glucose meters. So those take the type 1 diabetic patient takes a longer period of time than a general endocrine patient. In Puerto Rico, there's a lack of diabetes educators, or certified diabetes educators. So some of us, we need to do a lot of education that takes times out of, take time out of all that we need to do. In the States, there's more diabetes educators certified. So most pediatric endocrinologists in the state have their diabetes educator and they do most of the teaching, and the physician, the endocrinologists do more of the decisions in terms of the medical decisions. There's a lot of issues in terms of insurance coverage, in terms of pumps, sensors. When the technology starts moving fast, there's the insurance say, okay, hold on, I'm not going to pay for that yet because this is something new. So that's a little bit of the delay in terms of coverage, in terms of insurance company for the supplies. In Puerto Rico, for example, I'm talking to my day-to-day, we do see more patients per day than a usual pediatric endocrinology clinic in the States. And there's two reasons why. One is because of the huge need of endocrinologists and a lot of patients, so we try to accommodate more patients. Also, the part of, in terms of the economic wise, you need to, if you want to make a little bit more extra money to compensate for the lower payment, you need to see more patients. So that's pretty much day to day. Next slide. So these are a list of of the most common, some of the common diagnoses that we see. Obesity, this is an epidemic. Around 35% of the patients that I see are obese. In the States, there's pretty much the same percent of incidence of pediatric obesity. It's right now closer to 40% obesity and overweight. Growth disorders, that includes growth hormone deficiency, short stature, pubertal disorder, either early puberty or late puberty, all the the diabetes types, thyroid disorder, calcium, vitamin D, parathyroid disease. We do once in a while see those intersex disorders, ambiguous genitalia, and also hypoglycemia, adrenal disorders, rickets, diabetes insipidus, Turner syndrome. Turner syndrome is a genetic condition where we see, due to growth and in terms of pubertal development in this girls, pituitary disorders, congenital hyperinsulinism. So there's more conditions than that, but those are, I did a little bit of an overview of the main ones that we see. Next slide. Also, in terms of my day-to-day, I do a lot of, here in Puerto Rico, I do give a lot of presentation to peers, to general pediatricians, to my peers, other endocrinologists, adult and pediatric endocrinologists, also to other physicians. Do a lot of conferences for families and their patients. I also work at there's 2 diabetes summer camps here in Puerto Rico. I work with both of them. This summer we couldn't have them because of the pandemic, but we usually have those, and we kind of stay. One of them is this overnight camp, the other one is a day camp, and that's very, very fun, very interesting. Also, I have learned a lot about law, a little bit, in terms of getting things, helping patients with type 1 diabetes getting their supplies. So we have, when I moved to Puerto Rico, I realized that in the schools, there were not personnel to really treat those kids in terms of if they had a hypoglycemia, checking blood sugar for the younger kids, putting insulin. Although there were some federal laws that required those schools to have personnel for that, they're really not actually doing it. So we are able to get a law that right now we pretty much eliminated that hassle. In every school in Puerto Rico that have type 1 diabetes patients, they have at least 2 personnel that know everything about type 1 diabetes and be able to take care of those patients. Also, we were able to get the commercial insurances and Medicaid to cover insulin pumps, glucagon test strips, and all the supplies that previously were not getting covered here in Puerto Rico. Like I mentioned, I do some clinical research. I mentor residents in the Pediatric Residency program. And then, of course, I have those board member meetings every once a month or so. So that's my day to day. In terms of my medical condition, I have an insulin pump. I don't know if you see here. This is my insulin pump, and then I have a sensor, a CGM, which is right here. That CGM measures my blood sugar constantly. Every 5 minutes, it's measuring my blood sugar, and sends that information to my insulin pump. And then my insulin pump makes adjustment to the insulin. So I'm in what is called a hybrid insulin pump. Hybrid means that it responds to the blood sugar. The regular insulin pump is you need to enter the blood sugar and count your carbs, and then the pump makes the calculation. In the hybrid, I still need to count carbs and enter that information, but the rest of the stuff, the insulin pump kind of does it for you. Eventually, and hopefully we end up doing the artificial pancreas, but I'll show you a slide about that later on. So type 1 diabetes technology, very fast. Next slide. So this picture, I always put it when I give presentations about diabetes, and so this patient right here was the first patient to receive insulin. So in 1920, you see in the picture on the left, December 15, 1922, that was that kid, and 2 months later, he received insulin, and look at him 2 months later. So insulin was a miracle. It was discovered in Canada. Actually, it was a medical student and a surgeon, and they discovered insulin. Back then in the hospital, there were wards full of kids that they pretty much, they were fasting all the time. They kept them there. They would not give them sugar, glucose, dextrose, in order to end up in DKA, but they died of malnutrition. So insulin was a big thing, saved our life. If it wasn't for insulin, I wouldn't be here. Next slide. So that was in 1922 when insulin was discovered. Remember that number, 1922. Okay, so you see here, 98 years later, you can see that how things have progressed. There's long periods of time that there was pretty much not a lot of progress. In terms of glucose meter for home, it was up to 1971 when they started using, the glucose meter for home. Insulin pens in the 1980s. CGMs have been for a while. It's just that the first generation of CGMs were not that great, and the recent ones are better. And then you can see at the end it says closed loop. Closed loop means that that's what they call the artificial pancreas project, is that the pump and the CGM does everything by them together, and the patient do not need to enter any carbs. So right now I still need to count carbs and enter that information to my pump. When the artificial pancreas project, finishes the closed loop, you just put your pump and the CGM, and it'll take care of itself. So you don't need to enter carbs. So it has, during those 98 years, things have progressed, kind of slow for a long period of time. When the last 5 or 10 years, it's been faster. Next slide. So let's do there's a case study. I have 2 case studies I want to present. Pretty much this one you heard already the presentation about my diagnosis, but we have a 12-year-old male, no prior history of systemic illness, plays soccer, her lady was getting easily tired, long trips to the car, in the car, had to go to the restroom to void in the middle of the night, constant thirst, started to lose weight for past 2 weeks. The medical term is polyuria, urine avoiding a lot, polydipsia, constant thirst, the polys called, and started with multiple episodes of vomiting. Next slide. In the physical exam, the patient was dehydrated, no fever, a little bit tachycardic. It was having some increased respiration. So at the beginning, they thought he had asthma because he was breathing like that. Like it looked like he had difficulty breathing. And that's just in case. It's called Kussmaul breathing. and then had some breath that is kind of fruity odor. That's the acetone, the ketone smell. Next slide. So they did labs in the ER. They had a low body carb, blood sugar in 697. They did some arterial blood gases, and the pH was low, which is acidic. Okay. The acetone was positive, and the hemoglobin A1C. The A1C is an average of your blood sugar for the past 3 months. With 13, normal is up to 5.8. Diagnosis for diabetes 6.4 or more. So it was high. A low C-peptide. So C-peptide is a part of the insulin molecule. I don't know if you guys saw the first slide where it says, it's showing my name, and then the background, that was a molecule. That's an insulin molecule. So there's a piece of that molecule that is called the C-peptide, right? So if you want to know if a person is producing enough of his own, body insulin, you measure your C-peptide. So if it's low, it means that the person is not producing enough insulin, okay? And then this hospital was very, up to date in the ER. They did even antibodies, and the kid had a positive IA2 antibody, a positive islet cell antibody, and a positive GAD65 antibody. Okay, so those are 3 of the most common type 1 diabetes associated antibodies. Okay, IA2, islet cell, and GAD65. Those are the most common type 1 diabetes associated antibodies. So we talk about autoimmune conditions. So those are some of the antibodies that attack those cells, the beta cells. Next slide. So that patient, type 1 diabetic patient, it was in DKA, was admitted to the ICU, given insulin by IV, and then eventually transitioned to sub-Q insulin. So that was a type 1 diabetes de novo. You saw the antibodies, and the C-peptide is a way to measure endogenous insulin. Second case. So we have a 14-year-old male whose mother is concerned about a dark, velvety discoloration in the neck area of her son. The mother has been telling the son to you take a shower properly. She thinks it's kind of dirt in the back of his neck, and she keep telling him to use a lot of soap in the neck area. The patient drinks a lot of juice, constantly drinks juice, does not eat breakfast, plays a lot of video games, gets tired easily when he does exercise, so he does not do a lot of exercise, does not play any sports. Next slide. So this is the finding of that kid. So in that neck area, you see that area in the skin is kind of darker color of the skin. That's called acanthosis nigricans. Acanthosis nigricans, it happens when there's insulin resistance. So remember, we kind of went over that a little bit earlier, that the insulin goes to the blood, takes the glucose, and takes that glucose to the cell. So when there's extra fat tissue or fat in your body, that fat doesn't allow the insulin to get that glucose. So the pancreas starts producing more insulin. So the insulin levels go up, and that process is called insulin resistance. And when you have high insulin levels, one of the findings you'll see in a physical exam is that area there in the neck. It could also be in the axillary area, in female patients underneath their breasts. Everything, there's creases. That's an area where this can occur. And people who do not know that, that the mother was telling the kid, hey, you need to watch yourself. You're not, taking a shower properly. But that's secondary to obesity and insulin resistance. Next slide. So this is the graph of that patient. This is I don't know if it's clear enough, but this is a body mass index graph. So one of the things pediatric endocrinologists tell physicians, especially pediatricians, to keep a growth chart of their patients. This is something extremely important. Growth chart Every kid, doesn't matter if it goes when he's sick or when he goes to his regular annual checkup, you need to put your height, your weight. The pediatrician needs to do that in the growth chart. There's so many conditions that you can diagnose just by looking at the growth chart in terms of looking at if the patient is growing properly. You can see if the patient gaining weight, a lot of weight all of a sudden, or not gaining weight properly. And then the other part of the growth chart is the body mass index graph. Graph is from 2 years to 20 years. So we define obesity, okay, when the BMI, I don't know if I don't have control of the presentation, but I don't know if you can circle the 95 with your cursor right there, and just go with the cursor up to 95. So okay, so that's let me put my glasses on, kind of blind. So there you go. So yeah, that's 95. So when the BMI is at 95 or higher in pediatric patients, that's obesity. Overweight is from 85th percentile to 94th percentile. So go down to the 85th percentile, if you can, please. There you go. That's 85th percentile. Up to 94 percentile is overweight. So that's how we define overweight and obesity in pediatric patients up to 20 years of age. Underweight is below the 5th percentile. So you can see that point, the red dot, that patient, the one we were just talking about, his BMI was over the 95th percentile, so he was obese. So that was the reason why he was presenting with insulin resistance. He did not have diabetes, but he was at high risk of developing type 2 diabetes if he doesn't lose weight. I mentioned two things in the history: juice consumption and not eating breakfast. So all those sugary drinks, anything with added sugar, it could be natural, fructose or high fructose corn syrup. Anything other than water that is liquid is in pediatric patients the number one cause of obesity. So water, please, water all the time, okay? And breakfast, not having breakfast, also in pediatric patients, is one of the other main causes. They do not eat breakfast, then they eat their main meal, a huge meal towards the end of the dinner time or at bedtime, and those calories, you don't burn off those calories, you're going to sleep. So all those calories, what happens? They accumulate as fat tissue. And that's two of the main causes. There are other main causes of obesity, but those are two. Exercise as well. We recommend at least an hour of exercise, vigorous exercise, not walking around only. It's just, that you're tired at the end of the exercise, at least an hour. So those are, next slide. I think this is so in that case, the fasting glucose was 99, so it was borderline normal, high normal. Insulin, the normal insulin levels up to fasting should be up to 12. And he had an insulin level 37, extremely elevated. A1C is still within normal range. LDL, or the bad cholesterol, elevated. HDL, or good cholesterol, it's low. So we need to increase the physical exercise activity on this patient to increase that HDL. And his liver enzymes are slightly elevated. So you can see a little bit of fatty infiltration into the liver, or fatty liver in this patient. So we first start with exercise, modification of diet. Sometimes with insulin levels that high, we use metformin, which is a medication used for type 2 diabetes. We sometimes use it for severe insulin resistance as well in pediatric patients. Next slide. I think we're set with the case studies.
Hey, Carlos, can we go back to that previous slide? Do you mind? Can we go back one slide? Whoever's. All right. So here is a fasting glucose that's kind of okay, but the insulin level is quite high fasting. Mm-hmm. The hemoglobin A1C is pretty good, suggesting that it's not running high all the time. LDL and HDL are not terrible, and there's some transaminases, a modest bump in the AST and ALT. So where are you going with this case? This is interesting. is this an insulinoma or what are you talking about here?
No, so this is insulin resistance. Insulin resistance is it's secondary
in a pediatric patient though.
Yeah, in a pediatric patient. Yeah, so insulinoma, you need to see, you see the whole picture in this pediatric patient with findings of acanthosis, no hypoglycemia, because when you're talking about insulinoma in pediatric, it's not
Sure.
common.
Yeah,
We
they would
see
be very
congenital
hypoglycemic. Yeah.
Yeah, we see congenital hyperinsulinism, which is it can be either diffuse or kind of focal, which focal could be a limited kind of an insulinoma, but it's not that common. But this is extremely common because of the obesity epidemic that we're seeing. So you see a patient that, in this case, it was an adolescent patient, obese, glucose, you can see it's normal, borderline-ish. It's not pre-diabetes or impaired fasting glucose, right? 100 would be pre-diabetes. Over 125 or higher would be in diabetes range. So we have severe insulin resistance. So it's not insulinoma, it's insulin resistance secondary to the obesity. And that finding in insulinomas, you usually do not see that. You don't see that unless the patient is obese.
So this is a type 2 in pediatrics.
Well, he's not type 2 because his blood sugars are still normal. If that A1C or the fasting glucose was in the diabetes range, then he would be a type 2. So insulin resistance is what occurs right before prediabetes, and prediabetes before diabetes in this case would have been type 2. So he's not yet type 2. We want to avoid him getting into type 2. And that's where all this education, nutritional, psychological, is not only for the patient, it's for the whole family, because we know that you can tell the patient, the kid, not to drink juice, but when he opens the fridge, there's a gallon of juice there. It's going to be impossible for the kid not to drink juice. So it's something that the whole family has to do.
Carlos, having done 20 years of family medicine, private practice here in my hometown, have you discovered the magic formula about helping people lose weight?
So magic formula to pick. Okay, so it's you have to pick one thing at a time. If you tell them do all this stuff at the same time, they're gonna last 1 week, 2 weeks, and they're gonna give up. So you have to set realistic goals. Of course, you have to set up realistic goals. You usually start with, I look at their diet with the nutritionist and the whole group, and we pick, okay, what is the main issue with this patient? All right, so this kid drinks a gallon of juice every day. Well, let's start with that, okay? And then exercise, he doesn't do exercise. Well, let's start, instead of running a marathon, let's him start 3 days a week, half an hour. So you have to go slowly, okay? And there's some cases when the patient is already in type 2 diabetes, then you might be more strict. So there's no a magic wand in terms of, okay, do this and everything's gonna be perfect. That's why it's so complicated, it's frustrating, and for many patients. You can see all these diets coming out, the ketogenic diet, low carb diets. There's some pros and cons between of all of those diets, but there's no one diet for all, okay? There's some things that are basic for all of them, but you can pick, okay, low carb diets cannot help a lot for patients that are type 2 diabetics, low carb. Ketogenic diets in pediatric patients, we do not recommend that. It's too extreme. They're still in growth and they need their carbs. So ketogenic diets, for those of you guys who do not know, it's a total intake of carbs 50 grams or less per day. That's nothing. It's really low, especially for a kid that is growing. It's not healthy. Low carbs, you can do some low carb diets in pediatric patients who are more adolescents, younger adults. But in pediatric patients, you need your 3 macronutrients. You need your fat, you need your protein, you need your carbs. It's just kind of fine-tuning in which area is the main issue in that patient.
So Carlos, I believe we have a bunch of questions saved up. Cheyenne, you want to take it away?
Yes, that sounds like a plan. So So one of the common questions that we're also hearing, did you ever have any regrets about deciding on a medical specialty so quickly?
I do not have a regret at all. I really love what I'm doing. There's always, everything in life. There's some moments of that you look back and you say, I'm doing these things right, and I really do not regret what I studied. Um, I did this. I enjoy what I'm doing, and you'll see at the phrase at the last slide. But I think all of you guys that are planning or considering studying medicine, if you think you're thinking about it because of the money or economic wise, I don't think it's not the way to go. It's hard to go through all that process without really enjoying what you're doing. There's sometimes things that you don't enjoy, but you need to really like what you're doing. In terms of picking that, especially from the beginning, you can see my motivation started at a really younger age. I knew I wanted to do this. I knew I kind of want to help patients like myself. So it's a decision that pretty much was clear from the beginning that that I wanted to study medicine. But this is not common. My case is not common. Most people, most of my friends who were in medical school with me, when they went into medical school, they did not know what they wanted to study. And that's what medical school also is for. You just do all the rotations and you start looking, oh, I like this. I do not like this. I knew surgery. I just couldn't stand hours standing. My back will kill me. I don't know. I just couldn't deal with that. So you'll find through your experience in if you're in medical school, okay, this is not going to work for me. In my case, it did work for me, and I do not regret what I did.
That's great. Thank you for sharing that. So the next question is, have you ever reached a point where you wanted to stop fighting, and what did you hold on to, especially during medical school, to keep you going?
I say this 100 times. My wife, really. I mentioned that I turned 30 years with my diagnosis, diabetes. And I wrote my clinic have a Facebook page where we do a lot of writing in terms of education and different topics. And in August, I turned 30 years with diabetes. I wrote a letter. It was mainly directed to my patients or every patient with diabetes. And one of the points I said that, things in life kind of change your course, and diabetes changed my course. But during that period of time, what really carried me, especially in medical school, was my wife. Sometimes I felt like giving up. Seriously, it was when especially I was, raising two kids, the financial constraint. I actually, I'm gonna say this. I took a year of leave of absence in medical school, because I was debating. This is what I wanted to do. And I took a break, and I took my steps and this and that. I passed all the steps. But my wife was in my case, my wife was the one. Hey, let's go. I'm backing you up. We'll do this and that. Coming back to Puerto Rico, I was the one who wanted to come back. I know my kids. My wife really wanted to stay in Florida when we were living. And all of them, my kids, even from the youngest one to the oldest one, even though I knew they kind of wanted to stay, they were with me, and they don't regret being, kind of following my steps, and I don't regret the decisions we made. So really, it's in my case was my family who kind of in those moments. I'm a person of faith as well, so that also it's a big factor in my case. Also, another point.
Wow, well, that's great that you have a very strong support system. And so the next question here is, how is insulin access in Puerto Rico? Are the costs of insulin also insanely high like in the States?
It is even higher than in the States. Medications in Puerto Rico cost more than in the States, and in the States, you know that it is very expensive. So in endocrinology, we have treatments that are very expensive. Growth hormone is extremely expensive, very expensive. We're talking about 30, depending on the dose, $30,000 per year for many years, right? So it's very expensive. And so the access in terms of availability is there. Actually, one of the main insulins are made here in Puerto Rico. Lilly makes the insulin, Humalog insulin here in Puerto Rico. Medtronic, they make the insulin pumps here in Puerto Rico. So they're made here, but they get exported, and but it costs us more, even though they're made here, than what they cost in the States or in other countries. It's just something that you know, this is another issue that, but it's available. It's there. The access is there, but the cost is higher.
Right. That makes sense. Okay. Well, so one of the students was asking, can you please speak to the need for PAs in the endocrinology field? They said that they haven't seen a lot of information about this PA specialty, and have often been discouraged from pursuing it because some claim that there's not a demand for endocrinology PAs.
All right. So in Puerto Rico, unfortunately, the PAs are not available in Puerto Rico for different reasons. I would love to have PAs. It would actually, right now, well, I'm trying to see if I can be able to get a PA for my clinic. But it's, I think for endocrinology, especially for the cases in terms of type 1 diabetes and and not only type 1 diabetes, in terms of growth hormone therapy and pubertal, the Lupron and all this medication that we use, Fensolvi and Supralink for early puberty. PAs, I think, are provided that pediatric endocrinologists would need. I know I need it here in Puerto Rico. In the States, I'm sure they do. But really, to tell you the truth, I haven't checked in the States, you know, looking for you know, what are the opportunities for PAs, pediatric endocrinology. But with the amount of work, and especially due to technology, I think PAs, that's an area not only for the diabetes educators, but PAs, it's an area of growth. So, but I'm not an expert in that in terms of the you know, the opportunities for PAs, but I imagine that they would be.
Sure. Thank you so much. And so another question we have is, do you find that many doctors choose their specialties based off of personal medical diagnoses and experiences?
I 100% agree. I don't know. I don't have any evidence to that. But when I talk to my friends and the ward physicians, and hey, most of them, there's something in their personal experience that led them to go and do that specialty they did. I agree that personal experiences can lead you to what your professional career happens, and especially in medicine.
Right. That makes sense. All right. So then there's another question we have is, are there nutritional programs in Puerto Rico that give affordable access to non-processed fruits and vegetables for children, such as the Food Trust, in order to alleviate food deserts?
Say that again?
Sure. Are there nutritional programs in Puerto Rico that give affordable access to non-processed fruits and vegetables for children, such as the Food Trust, in order to alleviate food deserts?
No. Yeah, that's something that with the College of Nutritionists here in Puerto Rico, they tried to start different projects regarding that, but really did not move forward enough. But there's no programs regarding that. No, unfortunately, no.
Right. Okay. And so what kinds of research do you do as a pediatric endocrinologist?
So in my case, I do right now, one of the clinical trials that I'm working on It has to do with type 2 diabetes and a possible treatment for it. Right now, for type 2 diabetes in pediatrics, we only have two options. We only have insulin or metformin. In adults, type 2, there's so many, I'm not an expert on all the oral hypoglycemic agents, plus all the other GLP-1s, SGLT2s, and all of those, and SGLT2s inhibitors. But in pediatrics, there's only two options. So one of the clinical trials to add another option to those two. So I'm in one of those trials. The other trial, which I work, was the oral insulin trial. That one I closed earlier this year. Oral insulin trial is mainly not as treatment. It was in those patients that had high risk, who were recently diagnosed with type 1 diabetes and tried to prolong their endogenous production of insulin and see if that oral insulin pill will kind of help it prolong. The first results were not great. There was some light at the end of the tunnel in terms of higher dose of our insulin, but it didn't come up as we expected. And then the other studies is with the TrialNet that I do multiple studies on that. The main one is the natural history study in terms of studying family members with of patients with type 1 diabetes and determine their risk. And if they're in higher risk, then we do follow-up studies, OGTTs and different workup. So those are the three studies that I'm currently working on, and I'm applying for another one that has to do with technology and type 1 diabetes right now.
Carlos, what a remarkable story. This has just been an astonishing evening for us to hear about you and where you came from and your own struggle with diabetes yourself and how it brought you into endocrinology. Your amazing support group with your wife and your business and how you brought that all together. You have been so helpful to the 1,300 kids that were online tonight listening to you. And so I just want to thank you so much and ask everybody out there who's still online to please send thank you to Dr. Leyva on chat, please. So we just want to just thank you so much. And what a great evening this has been. And Cheyenne, thank you for hosting this for us. So this has been virtual shadowing, folks, and we're going to be here as long as you keep coming back. And we're spinning off to Dr. Salazar and the Virtual Observation Project, and we'll see where that goes. But if you keep coming, we're going to be here. So we just want to thank you so much. Now, Cheyenne, I think that we have some instructions about the exam to take. Can you do the slides there?
Yes. So is this open? I'm on my phone, actually. Yeah, there we go. Okay. So this is going to be the information for tonight's assessment. It's going to be due next Tuesday, right before the session starts at 6:59 p.m. Central Standard Time. And so you don't need a Quest-based account. You just have to enter the information that we have here. The pin is at the bottom of the screen here, and the password is Leyva, all lowercase. And so I think there was one more slide that Dr. Leyva had before the Quest-based info, if you wanted to touch on that as well.
Oh yeah. So that's one of the waiting area in our clinic, and there's it cannot be seen it, but I wrote what it says there. Is do what you love what you do. And those of you guys who are deciding what to study, just make sure you really enjoy what you want to do and what you're doing, because if you don't enjoy it, it makes it a lot harder. So good luck to all of you guys in your different aspects in your education. And I'm available. You can use my my email if you have any questions. You can I have no problem with that if you want to contact me over here in Puerto Rico.
Carlos, thank you so much. Carlos, on our session, there will be about 5,000 of our pre-medical and pre-PA and pre-NP students who will watch this. Each one of them will see 100,000 patients in their lifetime. 5,000 times 100,000 is 500 million. Carlos, tonight you've touched 500 million lives with your wonderful words and your amazing humility and how much you've studied to do what you've done to help so many people. So we are immensely grateful for your kindness, your humanity, and your amazing skill. So thank you so much.
Well,
Well, ladies
thank
and
you,
gentlemen,
Dr. Fowler,
thank you
for
for
the
joining
invitation.
us tonight. And we here at Virtual Shadowing, we'll be back next week, and we look forward to having another presentation for you. If you keep coming back, we're gonna still be here. So thank you, everybody. Take your exam, and we will talk to you next week. And with that, we will wish you a good evening. Good night.